What's the difference between like a balloon angioplasty, you got bare-metal stents, and drug-eluting stents? I'm throwing all these words out, but I want you to make that so people will understand what you're talking about.
Okay. So you have a blockage in an artery.
Right.
We determine that if you leave it alone, you run the risk of a heart attack. We need to fix it. You have a choice of either having a bypass operation or what we call a percutaneous coronary intervention, which includes angioplasty, which is a balloon alone, you take the balloon out, a bare-metal stent, that's a piece of metal that you leave in the artery after you balloon it to expand it, but it has no drug on the lining of it, or a drug-eluting stent, which has a drug lining the metal.
And the drug will do what?
Okay. So in the natural history of angioplasty, when angioplasty started and we started doing balloons, all we did with balloon angioplasty, the success rate was maybe 70%, and the restenosis rate, the chance of the blockage coming back, was probably around 70% also. Not too good. 15% of the people you did went for emergency surgery. Not
too good.
I would keep my wife up all night getting paged in the middle of the night with people closing their arteries. So angioplasty was an advance because it opened up the door for us to do new things. But it really was a primitive technique. It saved somebody from surgery sometimes, but you could only do it in limited cases. Cases where it was a straightforward single blockage in an artery, where the artery wasn't tortuous or calcified, and you didn't have great results. Around 10, 15 years after the introduction of angioplasty, we came up with the idea of stents. A stent is sort of like a spring on a pen. And it scaffolds the artery, and that revolutionized what we do. It took the success rate up to 90, 95%, pretty impressive. And the restenosis rate, the chance of the blockage coming back, down to around 15 to 20%.
Wow.
Better, but not perfect.
Right.
Not perfect. And you could do many, many more blockages. The problem with bare-metal stents is the metal in the artery actually cause the cells in the artery to cause a scar, called the fibroblast. So at the site that you put the stent in, a scar would form, and that would cause an obstruction to flow as well.
On itself, absolutely.
So it's not a cholesterol blockage building up again, but it's scar tissue. And that's what would cause the restenosis. Well, some very bright people thought, well, why don't we come up with a drug that will inhibit the fibroblast, the cell that makes the scar tissue, make it not work for the first 3 to 6 months when scar tissue forms. And if we knock that out, maybe we knock out restenosis. And that's exactly what happened. With drug-eluting stents, now it's not a drug released around your body, so there's no risk with it.
It's totally focused.
It's focused at that one spot, maybe 15 millimeters. And that drug inhibits the fibroblast from causing scar tissue, and the restenosis rates went down to less than 1%.
Wow.
And if you look at the trends since drug-eluting stents have been out, the decrease in open heart surgery has been dramatic, where the increase in stents have gone up. So the good news is you don't have to open up a body, you don't have to crack the chest and have someone in the hospital for a week with the risk of surgery. When we do it in angioplasty and a stent now, you could go home the same day. We could do it through the wrist, we could do it through the arm, through the groin, but it's basically you can go back to work the next day, so the downtime to the workforce is negligible and the discomfort is minimal. So it's really tremendous advances with stents. And now, you know, there has been some talk about bare-metal versus drug-eluting stents. The real issue with the two is that when you have a drug-eluting stent, you have to take a blood thinner for a fair amount of time.
6 months?
It's actually longer. It's up to 2 years now.
Wow.
And it's not Coumadin. It's either
Plavix?
Plavix or Effion is actually what we're using more often now. It's something that inhibits clot formation in the stent. And that's one of the issues with a drug-eluting versus a bare-metal stent. With a bare-metal stent, you only have to take it for a month. So let's say somebody needed to go for surgery in 2 months. I might put a bare-metal stent in them because I could take them off the blood thinner. The risk is the restenosis rate is higher. But ideally, for the average person coming in who needs to have an artery open, most physicians would agree a drug-eluting stent is the best treatment because we don't see it again. We fix it.